Hi everyone, my name is Greg Penny and I'm Director of Programs here at CPHA. We're going to get started now. So just for those that have been on this before, this is my standard housekeeping. So we're in broadcast mode only, so you're in listen mode only. We will have a formal Q&A section after Dr. Thompson's presentation, and you can use the chat feature throughout, and we'll try to capture that content as we go. We are recording the webinar and it will be posted on our website and on CPHA's YouTube channel. Once we have it available, we will send a link out to everyone that signed up for the webinar, and it'll be part of any other information we're sending out. So just a little bit of background on this webinar series. This webinar series is part of CPHA's project, A Public Health Approach to Cannabis and Other Substances, Prevention, Health Promotion, Surveillance, and Capacity Building. The purpose of our project is to engage a range of individuals and organizations from health, public health, social services, communities, criminal justice to enhance their knowledge of and capacity to address issues related to cannabis consumption and use. This part of our webinar series focuses on a range of issues related to cannabis consumption. The one thing I would like to draw your attention to is our tagline, which we use quite a lot, is normalizing conversation, not consumption. And jumping ahead to our next webinar, I have scheduled a webinar for June 13th at 12 p.m. with Dr. Keith Warner on consumption, risk factors, and food safety for edibles. We will be sending this link out to participants after this webinar. So as I'm introducing Dr. Thompson, take an opportunity to fill in these two poll items. We do have some poll items towards the end. So Dr. Kara Thompson is assistant professor in the Department of Psychology at St. Francis Xavier University in Antigonish, Nova Scotia. She works collaboratively with a team of researchers at the University of Victoria to explore variation and change in substance use patterns for young people across adolescence and young adulthood. Her research focuses on better understanding both the predictors and consequences of youth substance use patterns to inform policies and practices that will support positive mental health and healthy choices related to substance use for children and youth. With that, I will turn the webinar over to Dr. Kara Thompson.
Thank you, Greg. Can you hear me fine?
Yes.
Great. So thanks for joining me today. Today I'm going to be sharing with you a body of work that we are currently working on. It's an ongoing work right now. This work right now is funded by a CIHR CATALSA grant. So it was one of a handful that were recently funded by CIHR to look at how cannabis legalization would affect certain Canadian populations, including young people. And so that's really where our focus is. So legalization's coming, right? It's just around the corner at this point. And with approaching legalization, of course, we've seen increasing tolerance and acceptance of recreational cannabis use, and particularly marked shifts in youth perceptions of the risks of cannabis. Okay, and with legalization on the horizon, of course, we've seen increased concerns about the short and long-term effects of marijuana use on youth health and well-being. And so while we know some about the risks of using cannabis, there's still a lot we don't know. And so we're trying to contribute to that body of work. Not surprisingly, this may be a stat that some of you have seen before, Canadian adolescents are actually among some of the youngest and most frequent users of marijuana in the developed world. This data that I'm showing you here comes from the UNICEF survey in 2013, which showed that 28% of Canadian adolescents that are 11 to 15 had used marijuana in the last year. So what are the effects of marijuana? What do we know so far? I'm not going to spend very much time on this, but I just wanted to draw your attention to some of the things that we're pretty confident about. So when we think about the effects of marijuana, we can think about two aspects, right? We can think about the acute effects, which are really the result of being intoxicated, right? The risk while being under the influence of cannabis. And then we can think of chronic effects, which are really effects that result from long-term cumulative impact of exposure to the drug. Now, acute effects, things like impaired concentration, reaction time, short-term memory, of course, the evidence is quite clear that these acute effects impact traffic risk, for example, traffic crash risk. And is of a particular concern for young people, given it's the #1 cause of mortality already for that population. In terms of more chronic effects, the evidence is pretty clear that there is a risk for cannabis use disorder, for cognitive deficits, particularly for memory and attention for those that are long-term chronic users, that there are, especially for those who smoke marijuana, there are impacts on the lungs, and is associated with chronic bronchitis, and pretty strong evidence that there's an increased risk of schizophrenia and psychosis. But there are large gaps in our knowledge about cannabis, and with few exceptions, findings to date have largely been mixed with regards to whether or not cannabis is associated with physical and mental health problems. Okay? And most of our knowledge comes from U.S. samples, and where the regulatory framework is and the culture around cannabis is actually quite different. We'll talk about that a little bit later. So what we have been asking, and what I'm going to share with you today, are a few key questions. And one of those is, what are the different patterns of marijuana use for Canadian youth? Okay? Because while many use, they don't all use in the same way. And so that was what we'll talk about first. The second is, what are the predictors of these patterns? So what other things are co-occurring with these different patterns for young people and adolescents? Okay. And then how do these patterns actually relate to longer-term physical and mental health outcomes, as well as educational and occupational outcomes in young adulthood? So that's what we're going to talk about today. So the data that we're using for this series of studies I'm going to show you is called the Victoria Healthy Youth Survey. It's a 10-year prospective cohort sequential longitudinal study where we followed a group of 662 young people every 2 years from 2003 to 2013. So we have 6 assessments in total. And this is a random community-based sample, okay? So it's not a high-risk sample. It's a community-based sample. It was recruited through random digit dialing. You can see a little bit about the data here. At time 1, the youth were between 12 and 18. At the last time point, they're 22 to 29. So we have really captured the ages of 12 to 29 with this data set. And we have a pretty even distribution between men and women in the sample. So this is the data that all the subsequent results are based on. So before we talk about the different patterns, I want to just talk about the average pattern of marijuana use. And what you see here is this line just shows you kind of the average levels of cannabis use across the age groups based on our data. So on average, marijuana use increases quite steeply across adolescence. It peaks about 21 and then it subsequently declines. And this is standard across the literature. You'll see this in with other data sets as well. These increases, of course, are associated with increased independence and experimentation in adolescence. And the declines come as individuals take on more adult roles and that heavy substance use becomes incompatible with things like work and relationships and children. And we see almost the identical pattern with alcohol use as well. So this is the average pattern, but we certainly know not everyone follows that pattern. And so we sought to look at the different types of patterns that young people follow. So I'm not going to talk too much about how we came up with these patterns. We use something called latent class growth curve analysis, which basically allows us to differentiate our participants into different patterns of use based on what they reported their use to be across time. And so what we identified were 5 different use patterns. So the first pattern is what we refer to as our chronic users. It made up about 11% of our sample. These young people by 15 are already using more than once a week, okay? And they're persistently stay at that level across the entire developmental period. The second group we identified with the red triangles here, we've called them our increasers, and they make up about 20% of our sample. These young people are using a few times a month already by age 15. You can see they have a very, very steep increase in their use, peaking at more than once a week, but they do start to taper off in mid to late adulthood, but are still using at least a few times a month by age 28. Third group we identified, which is a bit of a unique group, is what we're referred to as our decreasers or our quitters. These are young people who also have very, very high adolescent levels by 15, but they are on a steady decline from that period. So really by early adulthood, they're no longer using cannabis with any frequency. And they make up about 14% of our sample. The fourth pattern we identified is what we've called our occasional users. Okay, they make up about 27% of our sample, and they initiate use kind of in the late adolescent period and really rarely use more than a few times a year. So they maintain a very persistent but very occasional use pattern. And our last group is our abstainers, the never users. So this group of young people pretty consistently some of them have tried it, but really have not used at all across the entire decade. Okay, so when we think about high versus low risk, and what's going to become very clear is that our chronic group, so our one that's very high, persistent at the top, and our increasing group, which is the red triangles, are our highest risk groups. So just a little bit more about these use patterns. So you can see these are just descriptives presented by group. Okay, you can see that there's slightly more males in our increasers and our chronic group. So our higher risk groups tend to have a few more males in it than females. We also can see that our chronic group has lower socioeconomic status than the other groups. If we look at how old they were when they first started using, you can see huge variability here with our occasional users using on average around 16, 17, but our chronic and our heaviest risk group using at 13. The marijuana use, what's presented next here, and it's just highlighted, was the frequency of use at the last time point, so at time 6. And you can see that the chronic use, most of them are using more than once a week by time 6. And I'll just draw your attention to the last line there, which is the quantity in which they consume when they do use marijuana. And so this is, they were asked to report on average how much cannabis they use when they are using, and this is roughly equivalent to 2.6 joints on the occasions when they use. Not surprisingly, given that they're using so persistently, their tolerance is likely much higher. So when we're reflecting on these patterns, one of the important things to do is to consider how they relate to what we know about patterns that have been identified in other countries. And particularly most research on trajectories or patterns of use come out of the U.S. And what we can say is that, one, we find a similar number of trajectories, and they have a similar shape. So most studies find somewhere between 3 to 6 patterns, and they almost all identify a very high persistent group, a group that kind of increases and then comes down, and a lower risk or occasional use group. But what really differentiates our groups from most of the studies is that this Canadian sample has a much greater percentage of high-risk users, meaning that we have more of our sample falling into these increaser and chronic groups. Not only that, but our chronic users are using at a higher frequency than what U.S. samples are calling chronic. So, for example, in some U.S. studies, the chronic group, maybe those are only using once a week or sometimes only a few times a month, where ours are persistently using more than that. What is similar, though, across our studies, again, is that early onset use is associated with the highest risk trajectories, and that's very persistent across studies. Those who use earlier tend to follow a pattern of use that is a much higher risk than those who have a later age of onset. So that really takes care of part one. What are the patterns of use for Canadian youth? And we have these 5 different patterns, some that are what we consider higher risk and some that are lower risk. And so our next step was to identify what kind of correlates, so what kind of things were happening in adolescence that were coinciding with these use patterns, and what were the implications of these use patterns on a variety of health and psychosocial outcomes in adulthood. And so we primarily use a multinomial logistic regression to look at these group differences. We include a significant number of covariates in our analysis to control for other variables. For example, when we look at mental health in, let's say we're looking at depression in adulthood, we're controlling for levels of depression in adolescence, okay, as well as controlling for other levels of other mental health problems. So all of the results that you'll see are above and beyond these covariates. Now, to simplify the results, we've used a bit of a checkmark scheme. So I'll just explain how you can interpret these check marks. You'll be able to, you can refer to the papers for the actual estimates. So the results are shown, all the results you're going to see are the results in comparison with the abstainers. So if there is a check mark, it indicates that there is a significant difference in that outcome between the abstainer and that group, that other pattern. Okay. The blue check marks are going to indicate that there's a significant difference during adolescence. So at time 1, when youth were 12 to 18, the blue check mark indicates that there's a difference in that variable in adolescence. The red check mark indicates that there's a significant difference from abstainers in young adulthood for the last time period from 22 to 29. Okay? And what you're going to notice as I show you these results is that our higher risk use patterns, so what we've called our chronic users and our increasers, have some of the highest levels of problems, and they seem to have a profile of risk that really increases the likelihood of long-term health and social problems. So I'll just preempt with that as we start going through kind of these series of findings on different health outcomes. So we'll just start with looking at other substances. For each of the slides, you'll see a reference to a paper at the bottom of that slide, and you can get access to these slides as well as some of the papers afterwards. This paper, we're going to start with substance use, and this comes from a paper that was just recently published in Canadian Journal of Behavioral Science. Okay. So for substance use, the blue check marks indicate differences in levels of substance use in adolescence. So you can see that the chronic users are not only using marijuana very, very heavily in adolescence, but they're also smoking, drinking heavily, and using illicit drugs. All of the groups are using more heavily than abstainers. Okay. You can also see the decreasers are also have slightly higher levels of illicit drug use in adolescence compared to the abstainers. So now you'll see the red check marks. I'll just draw your attention to the increasers. So this is how their substance use looks at the 22 to 29 age period. You can see the increasers now, while they weren't particularly heavy polysubstance users as adolescents, are now quite significant polysubstance users as adults. They are more likely to use tobacco and drink heavily, and they are also presenting with higher risk of alcohol use disorders. The chronic users are starting to kind of what we've termed specialize, so to speak. They are primarily using marijuana. There is some tobacco use. And while not statistically significant, you can see the coefficients there for cannabis use disorder are much higher for the chronic group compared to the other groups that we had sufficient power to measure. So with regards to mental health, we looked at a series of mental health outcomes. We looked at anxiety and depressive symptoms. We also looked at ADHD symptoms, ODD symptoms, conduct disorder symptoms as behavioral problems. And we also looked at psychosis later on, but not in adolescence. So in terms of adolescent levels, you can see that the chronic group clearly has very high levels of behavioral problems, all three behavioral problems that were measured. All of our user groups that were heavy adolescent users had high levels of conduct problems. Okay. There wasn't a lot happening with internalizing symptoms in these groups in adolescence, with the exception of decreasers having some evidence of some anxiety symptoms. This comes from the same paper with the substance use outcomes. So when we see the red check marks now are looking at what happens to their mental health as they move into adulthood, you now see that the chronic users are now exhibiting higher levels of depressive and anxiety symptoms compared to abstainers. So they're starting to have internalizing symptoms, but their externalizing symptoms are also persistent in terms of ODD. Okay. And we're also starting to see symptoms of psychosis emerge as well. So primarily the mental health concerns seem to be largely centered on our chronic group, although I will just point out that you can see that there's slightly higher levels of behavioral problems among our occasional users as well. So with regards to psychosis, the literature is pretty clear that cannabis use increases the risk of psychosis. But it's largely been contextualized as a risk for adolescents and young adults, being that that's the time period in life when psychosis tends to present itself. And so one of the questions that has emerged for us is whether or not this relationship between cannabis use and psychosis is something that is adolescent specific and age limited, or something that actually persists across time. And so in this paper, what I'm going to just explain what you're seeing here. In these graphs, what you're basically seeing is the graph on the left shows the association between cannabis use and psychosis symptoms between age 16 and 28. The solid line between the two dotted lines is the regression coefficients over time, and the dotted lines are confidence intervals. So when the confidence interval does not include 0, it's a significant association. And as you can see in that graph on the left, it pretty much doesn't include 0 from 17 on. Okay. The other chart on the left, on the right, is the association between having a cannabis use disorder and psychosis, and you can see that that relationship is significant from 23 to 28. Okay. So this, using our same sample, started to indicate that there is not a time-limited association between psychosis and cannabis, and in fact, that relationship may even strengthen over time for cannabis use disorders. We collaborated with a group out of the U.S. To run the exact same model, and both of the analysis are in the same paper, which is currently under review, and they actually have a sample that runs from 18 to age 64, and you can see pretty much the same pattern, that this is not an age-specific association, that no matter what age, higher levels of cannabis use are associated with higher symptoms of psychosis, pretty much at any age. So very interesting. So that was mental health. We've also done a paper focused on a variety of physical health outcomes. Now there are a variety of health outcomes. We know adolescence is a key time for establishing things like a healthy physical self-concept and establishing both health-promoting behaviors and lifestyles. So we looked at a variety of indicators. Physical symptoms was a measure of self-reported things like headaches, abdominal pain, backaches, dizziness. Physical self-concept is indication of kind of overall body satisfaction and perception of your physical capabilities. And then we have health-promoting behaviors, which are highlighted in the red there, which are physical activity, eating practices, and sleep. In adolescence, you can see our chronic use group are reporting more physical symptoms. Okay, they're reporting poor physical self-concept. They're also reporting poor eating practices and less sleep, okay, in adolescence. The decreasers are also showing some lower physical self-concept and poor eating practices. Now, in adulthood, we see that those physical symptoms become exacerbated for the chronic users. If you recall, all these effects at the 22 to 29 are over and above any effects that were present in adolescence because we control for baseline levels. So what we start to see is our physical self-concept worsens over time, our physical symptoms, worsen over time, and we're starting to also see lower physical activity for this group as well. Other physical health indicators we looked at were a number of serious injuries. Okay, so these are injuries that limited their daily activity in some capacity. We looked at some sexual risk behaviors such as early sexual debut, so early onset of sexual activity, number of sexual partners, and STI at time 6. You can see the chronic users reported more serious injuries, an earlier age of onset of sexual activity, and greater number of sexual partners. And in adulthood, we see them also reporting all of those things in addition to a greater prevalence of STIs. All of our youth groups reported more sexual partners compared to abstainers. And this paper is also under review currently. So then, in addition to physical and mental health and substance use, we looked at work outcomes. Now, socioeconomic status, of course, is a key determinant of health, right? And there's lots of indicators of socioeconomic status like education, income, occupational prestige, and all of those things are persistently and consistently linked to health status, right? And that adolescence and young adult is a particularly critical period to establish the foundations of economic well-being, such as educational attainment and securing full-time employment, et cetera. So they're all red check marks here because this is only at time 6. Okay, we looked at the associations between the trajectories and a variety of indicators of economic well-being. Importantly, we controlled for, in this model, high school grades, adolescent levels of substance use, and adolescent levels of symptoms of internalizing problems and behavioral problems. So these effects are over and above any of the physical and mental health problems we'd already identified as being important in these groups. So clearly, the increasers and the chronic users are both reporting lower educational attainment and lower occupational prestige. Youth in both of these groups were less likely to complete bachelor degrees compared to the other classes. Most were working as skilled laborers or unskilled laborers. Okay. Not surprisingly, these differences in attainment also then result in differences in earnings. Okay, and we see the increasers, in particular, the chronic users are very close, but not quite significantly different, but have lower income. Okay, and that lower income, in turn, creates difficulties in paying for necessities. We see higher reported debt among our chronic users. We also see self-reported delays in seeking medical attention. So our chronic users reported that they were less likely to visit the dentist, fill prescriptions, or delay mental health treatments due to their financial difficulties. Okay? And this is, of course, despite all the greater health needs that we just identified, right? We noted that they have higher levels of mental health and physical health problems, but now we also see that they have less access to health services to help them address these problems. And so we're starting to be able to really visualize kind of these cascading risks at play that are both contributing to use and also negative outcomes of use for these young people. The last set of results I'll show you is in relation to risky driving behaviors. Okay. You can see the references for this paper is below the chart here. Risky driving is, of course, something that is of particular concern given the pending legalization, and particularly for young people. We had 3 questions in our survey that asked about whether or not they had used in risky situations, whether they had been in a car when the driver, including themselves, had been using marijuana, as well as whether they've been in a car including with a driver who had been drinking. And you can see that these risk behaviors are all more prevalent among the increasers and decreasers compared to the abstainers. So just trying to bring it all together here, when we think about our higher risk use groups, our chronic use and our increasers, and we look at what adolescence looks like for these young people, we see that they have high levels of externalizing problems that are co-occurring with this substance use. Okay? They're reporting poor physical health and poor health-promoting behaviors, so they're not eating as well, they're not sleeping as well, and they are engaging in other risk behaviors. Okay, they are engaged in heavy drinking, they're engaged in tobacco use, and other types of substances. Okay, and in adulthood, what we're finding is that these groups, these higher risk groups, are also now exhibiting internalizing problems like higher levels of depression and anxiety. They're starting to exhibit substance use disorders, okay? More physical health problems, okay? Poor educational outcomes, as well as other indicators of economic well-being, and risk behaviors like risky driving and polysubstance use. All right, so what can we kind of pull from these results? What are our key takeaways here? One of the things that's really, I see a question about defining externalizing problems. Those are the behavioral problems that I was referring to, things like conduct disorder, oppositional defiant disorder, and ADHD. So one of the things that we don't pay a lot of attention to is the diverse patterns of use among youth. And I think this work is really highlighting that there are different types of users and that there are different relationships, both predictors and consequences, of those use patterns. Okay, so not everyone's using in the same way. We are certainly seeing, and I think this would be consistent with other literature, that early and persistent high-level use is associated with the poorest health outcomes. Again, I don't think we're surprised by that, but it is very clear that those types of patterns have the highest risks. It's also quite clear that there are relatively few risks for occasional users, and I'll pick up on that again in a second. But for the most part, our occasional users look quite similar to our abstainers and do not report the same types of problems that we're seeing with our higher use groups. What's really important is that we often are talking about marijuana as its own entity, as something that's going to exist and it be addressed as something independent of other concerns, and that's simply just not the case. It's not independent of other substance use and mental health problems and behavioral problems. Okay? It's very clear that it is embedded in other challenges that young people are facing, and that it will take us acknowledging and addressing those co-occurring problems to also tackle cannabis use for young people. It is notable that the co-use of marijuana and alcohol is particularly high Okay, so it's important that we don't lose focus on the high costs of alcohol use and abuse that we know a lot about. And these patterns of polysubstance use that are established early are incredibly difficult to change or alter. Okay, and so acknowledging that that polysubstance use patterns early becomes particularly important for prevention and intervention later. So acknowledging and addressing the context of use, so the context that young people are in when they're using, the co-use and the behavioral mental health problems that accompany it are going to be important for prevention and intervention. Right? We're going to need increased screening and resources for treating some of these externalizing problems that often lead to early onset. And it is important that we start to begin evidence-based education and prevention efforts now. Now, one of the questions we're still left with, and I think is on our mind often these days, is can cannabis use be used safely? Okay. These are the Canada's lower risk cannabis use guidelines that have come out, and they're certainly a step in the right direction. The research is we're still a long way off from being able to understand risk thresholds and what we mean by a safe amount. Most of the research on cannabis is based on frequency of use and not on amount. So we know very little about whether how much you use matters. We certainly suspect it does, but we don't have a lot of evidence that lets us come up with what a safe amount is. What I can say from what we've done so far is that a lot of young people are using in ways that are responsible and low use, and that we didn't find much increased risk of harmful outcomes for those that are using occasionally. So I think there is a threshold. We're just not sure what it is yet. The challenge, though, is that many youth believe that cannabis has low risk for everyone, and that is also not true. And so better understanding these use patterns and the consequences of specific patterns will help us work towards better able to answer this question: can marijuana actually be used safely? And we're working on some things to try to contribute to that, answering that question. So that's it for me. This is an ongoing project. Many of these papers are under review, and we have many more things lined up to work on over the rest of this year with our Catalyst grant. Just want to acknowledge that our funding has come from the Canadian Institutes of Health Research, and my contact information is here for anyone who'd like to get in touch with me regarding this work. Thank you.
Great. Thank you very much, Dr. Thompson. We're going to open it up to questions, everyone. So you can either put it in the chat or in the Q&A, and we'll ask the question directly. So I know this is from a really early slide. Jennifer had asked, I guess, in your trajectory analysis, did you use incident marijuana use at time 0?
I'm not sure I exactly understand the question.
I guess you started at time 1, maybe, and then maybe just one of your very first slides in your trajectory analysis.
To determine the trajectories, maybe. So we used what they reported at every time. So from time 1, 2, 3, 4, 5, 6, we used all the information across all the times to determine what pattern they fell into.
Okay, great. Thank you. I know some people are typing, so I have a question. One of the things you mentioned partway through was the early and heavy use, obviously, in youth and their health outcomes. But you also mentioned that also seems to occur also with older adults, so people who use persistently, I guess, and I guess would be considered chronic users, have similar poor mental health outcomes. Is that correct?
With the ones that are over time, is that what you're referring to?
Yes.
Yeah. So those analyses actually don't use the trajectories. They just look at any individual age. Do those who use more have more symptoms of psychosis? And the findings show that if you are 52 and using a lot, then you are at higher risk of psychosis. It is not just limited to adolescents who are using.
Okay. So we have a question regarding, can you comment on what lower risk products may be?
Lower risk products. I think the what is lower risk is going to depend on a few things. I think low risk is dependent on your own frequency and quantity of use. Okay, so it's how often, how much you choose to use when you do use, and the strength of the product that you choose. I don't think we have a great public understanding of variability in product strength based on THC levels and those types of things. I'm hopeful that those who will be selling those products will have the education needed to help communicate to people about product strength that will allow us to choose lower strength products. But I don't think there's a lower strength product right here yet.
Maybe as a follow-up, I mean, I think the premises out there is that edibles are safer than, let's say, inhalation. And
yes.
What would your comment on that be?
Yeah, I'm wary of the edible comment. It is in the lower risk use guidelines that smoking is the most hazardous form of administration, and I concur with that. I am hesitant to, with that information, I'm hesitant to still promote edibles, and primarily that comes from the length of time it takes for the edibles to take effect. Okay, so when you smoke it, the intoxicating effects are almost immediate. But when you consume it as an edible, it can take an hour, sometimes 2 hours, to feel the effects. And what that means is that people often can easily overconsume, or also get themselves into a situation before the take effect. So perhaps they're driving when they take effect. So I also think edibles have a bit of a danger in terms of storage in homes when they come in forms of things like gummy bears and that type of thing. I think it can be dangerous for children. So
I think there's a follow-up comment also that edibles have risks of pesticides, molds, and chemicals.
Absolutely. Yeah.
So we have a question regarding,
I agree.
what do you think of the 4-plant policy for home cultivation? Is this a health risk for adolescents and young adults?
Yes, I personally don't feel that it's necessary for people to be able to buy. I think it increases accessibility to young people, and I think anything that increases accessibility increases health risks. Yes, I do think it increases health risks for adolescents and young adults, but I think those health risks could also be mitigated with appropriate policies and enforcement of those policies. I know not every province is going to allow home cultivation or restrict cultivation in certain settings. So hopefully some of those policies will mitigate some of that risk.
So our question is, can you please elaborate on the evidence on co-use of cannabis and alcohol?
Such a great question. We're currently moving into some work looking at co-use, and we can define co-use a bit differently. So co-use could be just concurrently, that you're a user of both. But of course, the more important one is the simultaneous use, using both within a 3-hour period or so. And we actually do have measures of that, so that is something that we're working on currently. There is not as, the evidence is growing and is showing that there are additive effects. There is some work that suggests that the level, when you consume cannabis while intoxicated, that the levels of THC in your blood are increased. Obviously, there's obviously some risk for driving. We actually don't know very much about the risk for other things like mental health outcomes and such, but that is one of the things we're going to be looking at over the next year.
Just as a follow-up to that, Dr. Thompson, so in one of your slides, you were talking about the comparison of heavy drinking and versus abstainers, and I think all age groups across that and in all sort of categories were showing heavy drinking. Is that Is that partly due to experimentation at that age, or was there some other factor?
No, it is part of experimentation, and the abstainers are also drinking. They're just not drinking as heavily as as those that are also using marijuana. The reality is those two things really commonly occur. One of the most recent Stats Canada surveys said that of those who use marijuana, only 1% were not also drinking. Okay, so these substances are very normalized in adolescents and young adults. They're very commonly experimented with, but not all youth use in the same way. So clearly that makes a difference.
So this next question, and I believe there was some release last week from the U.S. on parenting and cannabis. But so, what are your views on and the research on using cannabis when parenting?
I guess it depends on what you mean by when you're parenting. You know, is it should you be, you know, is it just being a parent, or is it when you're actually engaging with your kids? You know, it's something that's becoming normalized. I mean, my personal views is that, you know, we should try to reduce exposure to children for as long as possible. Can you use it responsibly as a parent? Probably. You know, safe storage, only using when they're not around. I would encourage not using while you have to care for them regularly. There's some evidence. I'm seeing some questions about pregnancy. There's certainly some evidence that using during or throughout pregnancy may result in low birth weight for children and those types of things. You know, there's a lot of parents out there that probably use it, and I would just encourage them to try to use it in the way that at least affects their children.
In terms of when you were doing your surveys, and I'm assuming they were by phone, and so did you actually have a conversation, or was it did they do it digitally after that?
They were actually in-person interviews. They took about 2 hours. There were parts of the survey that the participant completed privately and put in a sealed envelope, things that were a bit more sensitive in nature, but the rest of the questions were asked actually verbally and recorded by the interviewer. Yeah.
So one of the reasons I'm asking is along the lines of, did you see any difference in sort of attitudes towards consumption and how their own views may have changed in any of those groups, or anything where they felt that they were being stigmatized?
We didn't really have any qualitative data
Okay.
in terms of this right now. I did just recently conduct some focus groups with students regarding with students who use cannabis regarding their perceptions of that type of thing, but I don't get the sense that the youth feel really stigmatized. I think there's a real common perception, at least among the youth that I talk to at university, that it's very normal and pretty well accepted. And so they were very happy to share their views on both the health benefits and the health consequences of their use.
I think this is talking about a little bit about pregnancy and breastfeeding, but are you aware of any policies that are being created across the country, or recommendations from organizations regarding to breastfeeding once cannabis is legalized?
I certainly don't know of any policies that are going to be created around pregnancy and breastfeeding. I assume, you know, we'll come up with recommendations similar to what we have for alcohol, where given how behind, I guess, we are on the research on the true effects of that, I think they're going to be cautious about recommending people abstain generally when they're using those substances, or at the very minimum keep their use to a minimum. I don't think we have a really strong understanding about a safe level to use during pregnancy or when breastfeeding.
I think this particular topic has triggered a few questions, so you can see. Do you have any information regarding the research on marijuana use and fertility?
Well, my understanding of the literature so far is that, particularly for male fertility, cannabis is a problem. That heavy cannabis use can can damage sperm that results in male infertility. I'm less clear in the research in terms of female infertility on that.
I mean, it does beg the question. One of the slides you had was sort of with people who had used chronically in the older age groups, they had increased number of sexual partners, and I think the natural consequence of that is obviously increased number of STIs, but there's no direct correlation between consuming cannabis and getting an STI, I assume.
No, I think a lot of these things are, what you're seeing is a profile of risk, right? A profile of risk behaviors, where you have a young person who's using a lot of substances, engaging in high-risk behaviors such as not using protection, driving while high. And so I think it's more, I don't think a lot of, some of these I just don't think are a direct consequence of any type of biological impact that cannabis is having, but more of the social culture in which cannabis is occurring.
Right. So there's a lot question here. Can you comment on the co-levels of THC and CBD? I've read that CBD levels help to mitigate some of the problematic effects of THC, but that with the higher levels of THC that naturally reduces the level of CBD that a plant produces. Is there any research regarding this?
Excellent question. I do not know the answer to that question. I wish I did, and maybe it's something I can look into. I mean, I actually not, no, I'm not particularly familiar with the co-use of those two products. I mean, I know a little bit about CBD and that people are using it to treat various conditions, but I don't know about their co-use.
I know from CPHA's, I personally have seen something on Marketplace where they had a conversation about traditional levels of it, and they said it moderated, but I don't know what the evidence is to support that. So, so we're going to have a couple more questions. So the one here is there any information that we can get from the states, Oregon, Colorado, California, Washington, I suppose, on the rates of some of these health outcomes post-legalization?
Sure. There's a ton of research coming out of those states in terms of, how perceptions of risk have changed, whether use is actually increasing. But what is unique about what I've just showed you is that we've been able to see the impact across a long period of time, right? We've been able to see, follow these young people for 10 years and see what the impact of using them long term is. And so, legalization in those states is still fresh and still new. There are definitely some great research happening where they are going to follow these young people to see if these health outcomes change. But we're in the early stages of really being able to evaluate the impacts of that post-legalization. So,
I did have a question regarding, so when you were presenting your results were for 2013, will there be a 2015 and 2017 cohorts also where data is collected?
No, we're not collecting any more data with regards to that cohort specifically. I wish we were, because now most of them will be married and with children, and it would be nice to follow them, but that study is complete at this point in time.
Do you think that there will be any differences in sort of the outcomes you pointed out with legalization? Now, considering 4 years ago legalization wasn't even being talked about, do you think there'll be any impact, or have you thought about how anything might change?
I think people will shuffle through our patterns a little bit differently. I think we're going to see more of our abstainers move into occasional users. In terms of the health impacts, I don't think the highest risk use groups are going to change that much, to be honest. I think we're going to see the most shift in those that wouldn't have maybe tried it, but now it's a little bit more normalized and they're going to try it. It's really hard to predict what is going to happen with this, but I think those who choose to use in low-risk ways are probably not going to increase their health risks dramatically.
Okay, great. Well, I'd like to Thank you, Dr. Thompson, for your presentation and the information. For all of you, for all those of you on the line, can you please look at completing some of these polls? Dr. Thompson, very informative. We really appreciate your time and all the work, and then we will circulate this to everyone. So thank you, everyone, for participating today and for your questions, and to Dr. Thompson for her presentation. We will post the recorded webinar on our website and on CPHA's YouTube channel and you will get an email with those links and the presentation. So with that, I'll remind you of our upcoming webinar, June 13th, with Dr. Keith Warner on edibles, and you'll get a link to that sign up also. Again, thank you, Dr. Thompson, and enjoy the rest of your day.
Great, thank you.